And now, oh, somebody is raising their hand. Not sure why. Okay. Well, welcome everyone. We're really glad that you're here and joined us today. The sun is peeking out, and that's wonderful. And I think that's a good sign for our speaker and our group here. I'm really pleased. So first of all, before we get started, the rules of the game, as you know, the rules of the seminar are that if you have any questions, post them in the Q&A box, which should be visible on the bottom of your Zoom screen. And if it seems like a question that is important to interrupt Kevin and have him clarify a clarifying question, I'll do that. I'll interrupt and ask the question. Kevin's happy to take those kinds of clarifications. And then we should have plenty of time for Q&A afterwards. So if you do happen to not remember and put something into chat, I'll just send you an email. I'll send you a chat and ask you to repost it in the Q&A and point you in that direction. When we get to the Q&A session, what I'll do is, if your name is obvious on the tag associated with the question, I'll bring you into the meeting and you can ask the question, repeat the question yourself and have a conversation with Kevin, which makes it a little bit more lively. Okay, so I'm really pleased to have Kevin Liebarger join us today. I just learned about Kevin's work, and I think that with our very strong interest in our community around computational techniques and the linkage and connection between computational techniques and demography, this is an opportunity to learn from someone who is in that field but is new to demography. I mentioned to Kevin that we'd had a great talk last week from Ian Kennedy around the use of some of these techniques for understanding racial segregation, residential segregation, and its continued imprint in American society. And so this is a slightly different approach, but I think for many of us in the audience, Kevin brings some interest. It will open up some thoughts and ideas for potential future collaborations, I hope. Kevin is a postdoctoral fellow in the Department of Biomedical and Health Informatics. He has a PhD in electrical engineering, computing and electrical engineering. And his particular expertise is around combining data-driven machine learning and natural language processing with important real world problems. He's going to be talking to us today about a project that involved annotating social medical records and understanding the social determinants of health using these techniques. And so without further ado, I'm going to turn it over to Kevin.
All right, well, thank you very much for that introduction. So can you guys see my slides okay? Great. So the title of my talk is Annotating Social Determinants of Health Using Active Learning and Characterizing Determinants Using Neural Event Extraction. And this is work that I performed with my collaborators, Mari Ossendorf and Maliha Yedisjan. And this talk is really summarizing a paper that we published in the Journal of Biomedical Informatics. And I included the relevant citation below in case you want to check out the full publication. So this talk is going to cover the intersection of natural language processing, or NLP, social determinants of health, or SDOH, and clinical text. Specifically, I'm going to describe how we used natural language processing to extract social determinant information from clinical text or clinical notes. So one of the questions that I frequently get about natural language processing is, what's this natural language business? And the best definition I've heard for natural language is that it's language that's created by a human for a human. And so natural language processing involves interpreting, analyzing, or transforming that natural language. There are many different areas or topics or subdomains within natural language processing, including, but certainly not limited to, things like information retrieval, machine translation, language generation, question answering, sentiment analysis, and the focus of this work, information extraction. NLP is a rapidly developing field, and this development is attributable to advances in machine learning, including deep neural networks and transfer learning, as well as more powerful computing in the form of graphical processing units, or GPUs. So patient data is stored in the electronic health record, or the EHR. And the EHR includes structured data like vital signs and lab results, and it also includes unstructured data like medical images and clinical text, clinical notes. And the primary use for this data is the care of the patient for which that data is about. However, the electronic health record data can be used in secondary use applications like large-scale retrospective studies or real-time clinical decision support systems in order to improve public health and advance clinical research. These structured data, like vital signs, can quite easily be incorporated into these types of secondary use applications because they're already in a structured format, they're quantized. The unstructured data, though, cannot necessarily always be directly used in these secondary use applications. In the case of clinical text, the text contains information, but in an unstructured form, and information extraction provides a mechanism for creating a structured representation of the phenomena that are of greatest interest in that text, so that it can be then used in secondary use to predict health outcomes or something like that. So clinical text or clinical notes document patient histories and treatments and are a fundamental part of the electronic health record and clinical decision-making. And a recent paper estimated that over 80% of the information about a patient in the EHR is contained in clinical text. And this text, these notes, they're created by clinicians, mainly for clinicians, although maybe to some degree, maybe for patients and maybe for lawyers, I don't know. But it's mainly like text that's created for a clinician by a clinician. And using the information that's contained within these clinical notes requires some sort of interpretation or extraction. And this is just a snippet of a note in our work that is describing a patient's social history or their social determinants of health. We can see that there's a description of tobacco, alcohol, and drug use, as well as their living situation. And clinical notes are very information dense. You can see that there's a lot of information that is tightly packed within this note, and it has important information that's quite important for assessing patient risk factors. There's the current tobacco use, current alcohol consumption, and a history of homelessness in this case. So clinical text contains a wide range of information, not just social determinant of health information, which is the focus of this talk, but many other types of information as well. And this text encoded information is relevant to to improving healthcare as well as improving public health. Accessing this text encoded information, though, requires extraction models to pull out a structured representation of the phenomena that is of interest. And all of this, the state-of-the-art extraction approaches or extraction models are based on data-driven machine learning. And creating or training these data-driven models requires high-quality annotated data to train the models. Here's a kind of a simple example at the bottom where there's some input text. This is a sentence from a clinical note describing drug use. And that could go into an extraction model that then outputs a structured representation of that text where it is clear that has outputs that could clearly be put into a secondary use application, like assessing the prevalence of methamphetamine use in a population. Clinical information extraction has several challenges. The first is data heterogeneity, in that the language that is used to describe the patients and findings can vary by institution, by medical specialty, by clinician. Additionally, the sort of quantity or availability of annotated clinical text is limited by the high cost of annotation and privacy regulations. And lastly, the phenomena that are of greatest interest may be infrequent within the available text. And in this work, we try to address all three of these challenges. So social determinants of health, or SDOH, are the conditions in which people work and live that impact health outcomes. And the goal of this work is really to create a more comprehensive patient representation that includes social, behavioral, and environmental factors in order to facilitate clinical research and improve public health. The social determinants of health, like by definition, I guess, obviously have some relationship to health, but there's mounting evidence that social determinants of health are in fact contributing to decreased life expectancy in the United States. And many of the key social determinants of health are described in clinical text rather than structured elements within the electronic health record. The specific tasks that we explore in this work are the creation of a new annotated data set that's rich with social determinant information. We extract detailed representations of social determinants of health. And in both of these tasks, we emphasize less frequent, high-risk health factors like substance use, homelessness, and unemployment. So now I'm going to discuss the new corpus that we introduced, the Social History Annotation Corpus, or SHAC. And just as a reminder, if you have questions as we go, feel free to put them in the Q&A, and I'll try to field those as we go along. So we created this new corpus that includes about 4,500 social history sections. Clinical notes are organized into topical sections. The social history section is where most of the social determinant information is contained. We used notes from MIMIC3, which is a publicly available EHR data set, and we used notes from the University of Washington and Harborview Medical Centers. We used an event-based annotation scheme. At the bottom of the screen is an example annotation, and in the corpus there are over 18,000 unique events, and the corpus is annotated for 12 different social determinants of health, including alcohol, drug, tobacco use, employment, living status, physical activity, insurance, environmental exposure, sexual orientation, gender identity, country of origin, and race. So in this event-based annotation approach, each event is characterized across multiple dimensions in order to capture information about status, extent, and temporal information. Each event includes a trigger, which is shown with the white labels, and the trigger essentially anchors and disambiguates events, and it can be represented by the event type, in this case, the label tobacco, and a span, the phrase tobacco use. And you can see that there are these arguments that are connected to that trigger in order to characterize the event. In our annotation scheme, there are what we've called labeled arguments. And these labeled arguments include an argument type, in this case, status, a span, in this case, the phrase quit, and there are subtypes. These subtype labels, like past here, essentially normalize the information in the span, mapping it to a fixed set of classes. And this facilitates the use of the information in secondary use applications. There's a question about bias. I think I'm super interested in bias. Maybe I'll save that question towards the end of the talk.
That sounds good.
In our annotation scheme, there are also span-only arguments, and these are the arguments that are shown in green, and they include an argument type like history and a span, in this case 7 years ago, and they don't include these additional subtype labels because the information in the spans can't easily be mapped to a fixed set of classes. This table summarizes the most frequently annotated event types in our corpus: alcohol, drug, and tobacco use, employment, and living status. Each of these event types is characterized by multiple labeled and span-only arguments. And I just want to highlight a couple of the most important arguments. For alcohol, drug, and tobacco, there's a status argument for which the subtypes are none, current, or past. For employment, there is a status label that has subtypes employed, unemployed, retired, on disability, student, and homemaker. And for living status, there's a type label that includes the labels alone, with family, with others, and homeless. And these subtypes provide a distillation of the information in the social history sections. The corpus includes training, development, and test sets, with the majority of the notes coming from the University of Washington, although still having a meaningful representation with MIMIC, this publicly available data set. And all of the development data and test data is randomly selected. However, a majority of the training data is actively selected, and I'll discuss what active selection or active sampling is in a moment. We can see in this histogram here that the most frequently annotated event types are drug, alcohol, tobacco, living status, and employment, with the other determinants occurring very infrequently within our corpus. So we needed to develop a scoring routine to evaluate both the inter-rater agreement in the annotation of the corpus and the performance of extraction models. And in creating this scoring routine, we thought about the secondary use application, that porting the data into a downstream analysis. And so we kind of frame this as what's called a slot filling task. So we can see that there are the same sentence annotated by two annotators, Annotator A and Annotator B. Both of the annotators identify this event for the event at the beginning of the sentence and an event at the end of the sentence. For this first event, the most salient information, information that you would use to represent the patient, would likely be that the event type here is drug, the drug use status is past, there's information about when the patient quit that drug use, and there's information about the type, namely that it's intravenous. For this second event, we can see that the event type would be drug, the status is current, and the type of drug use is cocaine. Now, when we inspect these two sets of annotations, we can see that the trigger spans, the white labels, are assigned to different spans. In this case, it's cocaine versus cocaine use. And for the status labels, there's the annotator A labeled as span use versus recent for annotator B. Now, with this slot filling interpretation, though, of the task and thinking about the most important information that's being annotated, we would consider these two sets of annotations to have similar meaning. They're semantically similar, even though they're not identical, even though there are some differences in the annotated spans. And this approach informed how we chose to score the routine, or score the performance. So we needed to be able to evaluate the trigger performance, the white labels, the label arguments in blue, and the span-only arguments in green. And the way that we did this is we aligned triggers based on their distance. So trigger spans that are closer together were aligned or connected and considered to be equivalent. And then if two different events, like an event in the annotations and an event in the prediction, have aligned triggers, only then do we compare the arguments, because we're trying to compare the performance in this like annotated structure, not individual elements. So for these labeled arguments, the blue arguments that have these subtype labels, we considered the arguments to be equivalent if they have the same type, in this case status, and if they have the same subtype, in this case current. And for the span only arguments, the green ones here, we just did a token or a word level comparison so that in assessing the inter-rater agreement or assessing the extraction performance, we can give some credit for partial matches, because partial matches can still contain useful information. We assess performance using precision, recall, and F1. And this bar graph here presents the inter-rater agreement for 300 randomly selected notes early in the project, where the performance is broken down by trigger, label argument, and span-only argument. And we can see that the performance is very high for trigger identification and for the label arguments. It's a bit lower for the span-only arguments, although it is still fairly solid annotator agreement. Okay, now I'm going to discuss the active learning component of this. This is like one of the core aspects of this work. So in annotating data, it is often the case that the available data is much bigger than the annotation budget. In this case, we had access to many millions of notes, but we were only going to annotate a few thousand notes. And randomly selecting samples for annotation is suboptimal for multiple reasons. The phenomena that are of greatest interest may be infrequent within the available data. For example, in our available data sets, homelessness and drug use were relatively infrequent. And additionally, there may be many samples in the available data that are very similar. And active learning provides a mechanism to sort of intelligently identify samples for annotation that will maximize the learning of the machine learning models. This figure here shows an example active learning framework. This is a pretty standard kind of approach where there's some pool of unlabeled data, in this case documents. A query function selects a batch of samples to be annotated. That annotated data is then used to train a classifier, and generally this would be the target classifier for the task that's being explored. And then that classifier generates uncertainty scores for the unlabeled data, which is used by the query function to select the next round of samples. And this process repeats cyclically until the annotation budget is met. And this type of active learning approach is fairly well established for single label tasks. However, it is less established for the more complex event extraction task that we've defined here for these social determinants of health. So in this work, we introduced what we've called the active learning using surrogate classifiers approach. And we implement this approach as a way to focus on the phenomena in our corpus that are most predictive of negative health outcomes. And here's an updated active learning figure where the only change is this classifiers block. In traditional active learning, the classifier here would be the classifier that is going to be used in to extract the information. In this case, we introduce this alternate classifier, the surrogate classifier, in order to influence the sampling or the querying of the data. And I'll describe this a bit more on the next slide. This query function that is selecting samples for annotation has two primary considerations. Sample, in this case, social history informativeness, which is the potential for the sample to reduce classification uncertainties. That will tend to be trying to find samples that are near the decision boundary for the model. And the query function considers the diversity of the samples that are selected for annotation, and that it will try to select a wide range of samples and avoid having samples that are selected that are similar. So we implement this surrogate classifiers approach because not all of the arguments in our annotation scheme are equally important, and we wanted to be able to focus, this informativeness assessment on the arguments that are most predictive of negative health outcomes. And we did this by taking the event labels and then mapping them to a set of document level labels, essentially mapping this event extraction task to a much simpler text classification task. So here for each of the different event types that we're focusing on, the substance use, employment, and living status, we identified the single argument that we thought was the most important, and we represented each social history section using these 5 set of document level labels. So in this event annotation, we can see that the alcohol status is none, the tobacco status is current, and so those would be the document level labels. And we predict these document level labels using this surrogate classifier framework here, where each document or social history section feeds into a BERT model and a bidirectional long short-term memory network, and then self-attention is used to generate the predictions for these labels. And I recognize that I'm not going to dig into the details of this machine learning piece, but basically this sequence maps the document into a vector space so that it can be used in prediction. And then the entropy scores from these predictions are used to represent the informativeness of the samples. This slide presents the active learning query function that we implemented, where Q of B is the function, and B is a batch of samples that is selected for annotation. And the goal is to find B to maximize Q of B. In this formulation, there's a diversity scoring component and an informativeness component. Here, SI is a measure of the similarity between a given sample and the rest of the samples in the batch. And so 1 minus SI could be interpreted as the dissimilarity between a sample and the other samples that have been selected in the batch. And this UI is the uncertainty score, which we've calculated just as the sum of the entropy scores from the surrogate classifier. So this function is going to try to seek out samples or a batch of samples that have high diversity and high informativeness or high uncertainty. Now I'm going to present the information extraction framework that we use to extract the full social determinant representation. This on the right is the multitask event extraction model. We specifically designed this to achieve high performance in low resource settings, which is to say on smaller or small data sets. And this model shares information across the different event types like alcohol, drug, and tobacco, as well as different argument types. And it explicitly learns dependencies between the annotated phenomena. So a given sentence from a social history section feeds into a bidirectional encoders representations for transformers or BERT network. And this maps the sentence into a vector space. And that vector representation then feeds into a bidirectional long short-term memory network, another kind of neural network that adapts that vector representation to this task. And then that vector representation feeds into these separate output layers that generate each of these sets of predictions. The trigger prediction is predicting whether or not a given event is present in a sentence. For example, whether or not alcohol is present in a sentence. So it's generating binary predictions to indicate whether each of the events is present in the sentence. And it uses a learning strategy called self-attention. The labeled arguments, for example, status for alcohol use or status for tobacco use, is predicted here also using self-attention. And the label prediction is informed by the vector representation of the sentence coming from the bidirectional long short-term memory network and from the trigger predictions. And then the span-only arguments like frequency and history are being predicted by conditional random fields or CRF models that are informed by the representation from the LSTM and the label probability distributions from the labeled argument predictions. Now I'm going to highlight a few of the results from this work. So early in the process, we wanted to assess the goodness of our active learning approach relative to randomly sampling. And so what we did is we took an initial batch of samples, and we added a set of random samples to it, assessed the performance. And then we took a batch of active samples of similar size and added that to this initial batch and assessed the performance. And here's the performance on the left-hand side is for the surrogate classifiers, and the right-hand side is for the multitask event extractor. So this performance over here for surrogate classifiers is for this proxy task that we only introduced for the purposes of the active learning. It's not really the target of the work. What we really care about the most is the extraction of the full representation of the social determinants of health that's coming from this multitask extractor. And if you compare the orange, which is the performance with random, to the performance with green, which is the active performance, you can see that there's a statistically significant improvement that is achieved using active sampling as opposed to random sampling. Now, I will concede that even though this is a statistically significant improvement, the delta is not very large. And so we dug into exactly what the model was learning and where the performance gains were coming from. And we found that the model was having the largest performance gains using the active samples as opposed to random for less frequent but extremely important health risk factors. So including things like current and past drug use, tobacco use, unemployment, homelessness, and living with others. And because these phenomena like homelessness are relatively infrequent, improving the prediction of homelessness doesn't fundamentally change the overall performance, but it does provide a performance for the categories that we probably care the most about. This slide, or on the left-hand side here, is the performance of the extraction model on our withheld test set, including the mimic partition in blue and the UW partition in orange. And you can see here that the extraction model performs a little bit worse on the UW data than it does on the mimic data. And this is because our UW data has much higher rates of hard to classify social determinants of health, including higher rates of drug use, higher rates of unemployment, and higher rates of homelessness. On the right-hand side is the inter-rater agreement that I presented earlier in the presentation on the mimic notes. And if you compare the extraction performance on mimic versus the inter-rater agreement for the mimic notes, you can see that the performance is very similar. And in fact, the combination of our annotated data set and the extraction architecture is achieving human level performance in characterizing these social determinants of health. We're extracting this social determinant information. Now I'd like to conclude my talk by talking about some impacts of this work and how this data set and extraction framework is being used. So in this work, we introduced a new annotated data set that is relatively large and has high quality detailed representations of social determinants of health. We introduced an active learning framework that uses a simplified set of surrogate classifiers as a proxy for a more complex extraction task. And we demonstrate that this improves extraction performance over random sampling, and that we have the largest gains for less frequent but high risk factors like homelessness and drug use. And lastly, we present this multitask extraction framework that shares information across the different labeled phenomena, and we demonstrate that it achieves human level extraction performance. So this trained extraction model is integrated into the UW Enterprise Data Warehouse, and it's being used to create more comprehensive representations of patients as we explore different types of outcomes. For example, the likelihoods of different cancers, the hospital admission length of stay or hospital admission mortality. And we've created a de-identified version of the corpus that is going to be released through the National NLP Clinical Challenges, or N2C2, where participating teams will experiment on this data set and develop new and innovative extraction approaches. And then the best performing or most novel approaches will be invited to present at a workshop that we're going to host. Registration actually will be opened up fairly soon, and the challenge will be conducted next year. I've included a link in case anyone in the audience is interested in exploring this task. And this shared task will contribute to the advancement of clinical NLP and increase the awareness and accessibility of social determinant information. I'm happy to take any questions that you may have.
Thanks, Kevin. Super interesting. And I think what maybe do you want to take that first question that was in there, and then I'll bring Kyle into that.
Okay, yeah, that sounds great. So the first question is, how do you imagine your work being used clinically, and what data biases are you aware of that might impact how your work is being applied? Excellent question. We were actually, before the talk started, we were having a little side chat about biases. So in terms of how it could be used clinically, so this is probably most relevant to this slide here. So we have this extraction model that achieves the same performance as humans, and we can take it and apply it to vast quantities of text, to hundreds of thousands or millions of notes to extract these phenomena. And then we can use the extracted information about substance use, employment, and living situation in order to predict health outcomes. This could also be used in like cohort selection. So for example, if you want to identify a pool of patients who have a history of homelessness, like that would be a good candidate, or patients that have a history of smoking use. And and then in terms of the biases, I mean, I think this is a good question. So in terms of there are kind of two ways to maybe think about the bias of the work. The first is that the patients for whom the patient populations of these hospital systems, Mimic came from Deaconess Hospital on the East Coast, and UW will of course influence the prevalence of the different types of social determinants that are annotated and that the model will extract. So for example, and that bias can also be related to the to when the notes were created. So like a good example for
Kevin, can I just interrupt for a second?
Yeah.
Are you jumping ahead to Kyle's question, or are you still answering the first question? I just want to make sure.
Oh, I was still trying to answer the first question.
Okay. It's sort of related.
Okay.
And maybe what I'll do is have Kyle ask his question, and you can answer it because it's related to.
Okay, yeah, absolutely.
Yeah. So Kyle, you can unmute. Yeah.
Yeah, I was actually, interested in hearing what Kevin had to say about this, because I think he was veering towards an answer to this. So I was just thinking about the social processes that lead to the construction of these texts, and I'm thinking about biases that clinicians might bring into the production of the texts, and how that might influence the utility of the information that you extract from it. So maybe continue on the path that you were on, but think a little bit more explicitly, maybe tell us a little bit about how you think about the value of the data that comes out of this. Very good question. And this is something that I have been thinking about a bit. So the thought that where I was headed in terms of a bias that I know is in the model, that is, it's not a racial bias, but is that like our data set doesn't have any references to vaping, for example. And that's an artifact of just the time range for
the notes that were used. And so there are, so like there is a sort of a temporal bias to this data, so that like if we apply it to notes from today, especially maybe for younger populations, maybe it misses some of those, some social determinants. But to Kyle's question, I don't necessarily, from looking at these notes a lot, I can't necessarily think of like really strong bias, like negative biases that I've seen in this corpus. But I will say that there is some recent work that has explored the bias in clinical notes in general, and it has shown that there is bias, and that can affect clinical decision making. So, for example, certain patients of certain demographics will have notes where there's like there are cues that the provider does not believe what they're saying. And so maybe there's like quotes around things, and this kind of like this like belief about, or this bias related to like disbelief can affect how somebody would interpret that note. So this is like a growing area of research.
That's interesting. Thank you. Ian, you're in the queue.
Cool. Yeah, thank you so much. Also, I love that question that you've just been talking about, and I think it would be super cool to hear more about that. But I want to use my question to ask, kind of as someone who's maybe like a journey person, NLP user, and like definitely applied NLP. So I'm not, developing my own models. I'm really interested in the kind of the choices that someone in computer science or engineering are making. And so, yeah, I have those two questions. One, why did you decide to layer that BERT and by LSTM models together? And then relatedly, like, do you think that would be generalizable to other cases where there are similar complex categorization tasks? Or do you think that it's like case by case, and we have to be careful how we build those kind of ensemble or multi-model models for those particular cases? Yeah,
excellent question. So in this, so just at a very, very, very high level, so this just so people understand, this BERT model, it's a very large language model that has hundreds of millions of parameters, and it's all state-of-the-art results in NLP, I feel like, are coming from it. But because it is so big, it is completely impractical to train this BERT model on a CPU. You have to use a GPU. In this case, I was doing some of my work in an area where I had access to a GPU, but the data that I had protected health information, I had to be using a wimpier computational resource. I only had a CPU. And so the reason that I did this is I only used BERT to generate a representation of the sentence. I did not train the BERT model because I didn't have the computational resources at the time. And then I used the bidirectional long short-term memory network to adapt the BERT representation to my task. So to Ian's question, this using an LSTM between BERT and the output is not generally I would not recommend it. I did it because of a specific computational constraint. Does that answer your question, Ian?
Yeah, that makes tons of sense. And yeah, I didn't think about the protected data issue, and that seems like even more cool as a way to like work around that. But that means in other cases, we can just use a big model and then fine tune it on our case, and we don't even need to build out the use, or like, depending on the use case.
Yeah, and I think, I haven't run the experiment, but I'm fairly certain that if you were training the BERT model and you nix the LSTM, you'd get better performance. One just small comment that I would make about the BERT model relating to the questions about bias is this. this BERT model, it's this massive model with hundreds of millions of parameters. And the reason that it can work is you can use unlabeled text to first train the model, to train all these hundreds of millions of parameters. And then when you want to, you can adjust it or fine tune it to your task by just doing a slight adjustment of the parameters. And one of the things that is coming out is that because this model is trained on text, and text has its own bias because it's created by humans, that there's some interesting work that is showing how biases are coming out of the BERT model. And I don't necessarily think that negatively impacts like the performance or introduces bias result in my extraction task, but certainly it's something that would be important to consider if there was more of a racial component to or gender component to a task.
Super. I think I'm gonna go to Anne because I'm not sure about Daniel Kives, but Anne, you're on deck.
Okay, well, thank you. That was a fascinating presentation, and I'd have to go back and look at the paper. I was wondering about biases in the data. I was wondering about biases in the algorithms you use, so the extraction model, or is there a possibility that the active learning parameters are actually introducing biases? Am I misunderstanding the possible potential there?
So to be clear, the active learning is intentionally biasing. Like that is the,
right. Biasing.
It is for sure like that. Yeah, that is the goal. Like,
so I understand it's biasing towards rare events that are informative, but I'm wondering if that induces other kinds of biases that might be unintentional.
Yeah, I think that's a good question. I guess it depends on, in terms of, if bias is intended to be related to like racial bias or gender bias, that's not very prominent in our data set. There are like he, she pronouns, for example, but like it doesn't seem to me that that's like a big part of the social history sections that we had. I don't. In one of the things is so we in this. I presented the distribution here and showed that we have these first 5 event types are really infrequent, and the others were infrequent. And in our early sampling, we decided to focus the active learning on these frequent categories, and we decided to not include these other categories because we were concerned that we would overly bias the data set. So, for example, if there are only in our whole data set, there are 49 references to sexual orientation. If we demonstrate that it's very infrequent within the available data, if we were to, we were concerned that if we made that one of the targets, that then we would make the data no longer, we would make it not representative of the types of notes that the model is likely to encounter. So we were trying to balance like bias in the data, but not necessarily in like an equity kind of way, if that makes sense.
Yeah, it does. I was just wondering about sort of unintentional biases that you might be introducing that would obscure what you're trying to learn about.
I can't think of like specific biases, that I can think of that are in the that are in the data.
Yeah. If just a quick follow-on is if you included environmental exposures, then you didn't include that, right? And so if you did, do you think you would get different results?
Oh, sure. Yeah, for sure. Like, so with if we had used, included, so when we did our active selection, we were considering substance use, employment, and living status. If we included environmental exposure in the criteria, then the model would, I feel pretty strongly that it would increase the prevalence of environmental exposure. So that's something that we could have captured more of if we had made it just basically we made a different design choice.
Interesting. Thank you.
Thanks, Kevin. Mary Bridget Waters, you're next.
Hello. I just have this sort of like a general question. Do you think it's possible for EHRs to be improved so that they can kind of collect this data in a structured way for research while still serving patients and then also being user friendly for clinicians? And then if you think this is possible, do you know how far away from this we might be?
Yeah, I think that's a good question. So, I mean, first of all, I'm not like an expert in the EHR systems, but certainly there are EHR systems that are out today where very detailed smoking information can be entered through a series of like checkboxes and drop-down boxes. And so, and that extends to other phenomena, including alcohol use, for example, not necessarily to homelessness, I don't think. But it is certainly possible to create a wider sort of barrage of structured inputs that a clinician could enter. But there's sort of a couple problems with that, is like, as the number of these structured options increases, the workload, the documentation burden on the clinicians increases. And also it is, for many of these determinants, it might be hard for the clinicians to really express what they're seeing. You know, by the clinician describing their findings in free text, they're able to add a lot of nuance to the note. And I think that one of the things that's maybe important to keep in mind is, like, there's the primary use for the note, which is the patient care. And then there's this secondary use, the type of work that I'm exploring here. And that nuance is probably important to both, but we certainly wouldn't want to lose important nuance related to maybe the patient's housing situation just to facilitate the secondary use. And so there's a balance there between the goal of the data and the workload for the clinicians. I do think that it seems reasonable that maybe, I guess the hope would be that this type of extraction could just be done automatically as part of like an EHR add-on. And that's, you know, we're applying these extraction models to the repository of notes that UW has, but it's all kind of like the clinical research facing. It's not necessarily patient care facing at the moment.
Thanks, Kevin. David, nice to see you today.
Yeah, good to see you, although I don't have my camera on, but that's all right.
Yes. I see your name.
Yeah. So I had thank you, Kevin, for presenting. I had a couple questions. The first one is very quick. How many months did it take to complete the results in your presentation? You know, how much, labor is involved in producing these results? And then secondly, I think you sort of alluded to this, but I wasn't, I'm not sure if my memory captured it, but how many patients from the UW Harbor Review were included in the NLP analyses, and what was the total patient population? Because, it is a very interesting, Harbor Review is a very interesting patient population when it comes to social determinants of health. Harbor Review, as many of us know, treats a low income population much more than other healthcare systems. I think Harbor Review sees a lot of patients that don't speak English. I think they have translation services for over 50 to 60 languages that are offered. So it's a very, very diverse population, and that may have more social determinants than perhaps other delivery systems. But that aside, how long did it take you to do this work, and how many patients were included?
Yeah, good questions. How many months did it take? I don't know. I mean, my guess is like from drafting the annotation guidelines to the paper being published is a long time, of course. But like the annotation portion of the work, we had 4 medical students that were annotating the social history sections. And certainly it probably took a couple months to develop the guidelines, have the annotators like annotate some notes, assess the agreement, and update the guidelines and train them. So like the guideline development, training of the annotators was probably a couple months, and then there were at least then 3 months of annotation work by the annotators, and that's just to create the data set, and then all the experimentation on top of that. So my guess is it's something like a year for the annotation and the modeling, maybe a little bit less.
Thank you.
I actually don't think I ever counted the number of patients. I don't think that I think we just looked at things at the note level. So it's possible that within the 4,500-ish social history sections that maybe a patient is in there multiple times. But so something on the order of 4,000 patients is what I would sort of estimate. And you're definitely right that the Harborview notes have quite a unique patient population. I mean, that's where a lot of polysubstance abuse and homelessness, some compared to the mimic data set that comes out of Beth Deaconess is, it doesn't have, I think I couldn't find any references to homelessness, for example.
Yeah, that's what I would expect. So thank you.
But I think that your question, it relates to, this kind of gets back to the bias that there are plenty of hospital systems in the US where if you were pulling the notes from, you just might not never find, but like the prevalence of homelessness in the notes might be so infrequent that it would be quite challenging to create a representation of that.
Yeah.
Thank you, Kevin. I think the last question is one that Daniel Kai wanted to ask, which is, could you elaborate on what you think are some of the possibilities? It's very exciting work. I think we've gotten a lot of engagement from our audience, and wondering what you're thinking about next steps.
Yeah, well, I mean, I think that in general, right now, the social determinants of health it's just like a really hot topic. And I mean that admittedly in like some self-serving ways that like NIH is super interested, but like clinical researchers are interested there. And so I think that, we have this, one sort of set of social determinants of health with the substance use, living situation, employment, but this is by like no means a comprehensive representation of social determinants of health. And so I think that there could be some interesting work exploring like the social determinants of health for specific populations like children, or trying to get at other social determinants of health that aren't really in our data set, like food insecurity and other things that could be maybe represented in text.
Yeah, great. Well, I do want to invite our audience, and we have many people who study homelessness in our community, in our group of scholars at CSDE, as well as other dimensions of social determinants of health. So I hope everybody will feel comfortable in reaching out to you and connecting on your data. And
yeah, absolutely.
Yeah. And I guess let us know when the challenge goes live, because we can post it out to our community.
Yeah, absolutely. And yeah, if anyone has any questions, or you want to brainstorm a problem, I'm available. Just shoot me an email.
Yeah. Well, thanks everybody for being here today. I hope you have a great weekend. And thanks, Kevin, for joining us.